Hi everyone, today I'm going to talk about Chapter 2, Immunity. The immune system is incredibly important as it protects the body against an array of microorganisms, removes damaged cells, and destroys cancer cells. The immune system provides this protection through two major actions, defending and attacking. Optimal immunity requires intact, nonspecific defenses, which include skin, mucous membranes, phagocytes, and the complement systems. It also requires a functional lymphatic system, an efficient innate immune response, operational inflammatory response, and an appropriate adaptive acquired immunity. There are two types of immunity, innate and adaptive. Innate immunity provides immediate protection and is nonspecific in that it will protect against all invaders. Adaptive immunity is acquired and can take 7 to 10 days to provide protection, but it is specific to the antigen. And an antigen is any substance that the body recognizes as foreign, which can include microorganisms, environmental substances, drugs, and transplanted tissues. Antigens are what trigger an immune response, so it is vital that our immune system knows how to identify and respond to an antigen within our body. Table 2-1 on page 58 of your textbook discusses the cells of the immune system more in depth. So, innate immunity, also known as the nonspecific approach, relies on physical and chemical barriers that indiscriminately protect against all invaders. The most prominent barrier includes skin and mucous membranes. And while the skin protects the human body from microbe invasions, some passageways, such as the respiratory, GI, and GU tracts, allow direct access to the body's interior. To protect these systems, the passageways are lined with the protective mucous membrane. These passageways also have the ability to wash off microorganisms from their surface. For example, vomiting can be an attempt for the body to remove a noxious substance from the GI tract. And cilia are found in the respiratory tract and ear and serve to remove particles. Mucus also lines cavities exposed to the environment, such as the respiratory, GI, and GU, and it helps keep membranes hydrated and traps and expels microbes. The physical barriers also include chemical barriers to prevent invasion. For example, the skin produces a slightly acidic substance that inhibits microbial growth, sebum and sweat. Hydrochloric acid in the stomach destroys many digested bacteria, and tears and saliva contain lysozyme, which is an enzyme that dissolves bacterial cell walls. Even microorganisms participate in innate immunity. Normal flora, which resides on the skin, GI, and GU tracts, does not usually cause disease unless there is an imbalance or the person is immunocompromised. These microorganisms can contribute to the immune defenses by secreting chemicals and protein molecules, as well as by blocking pathogenic attachment. An example is Staphylococcus epidermis, which is part of the normal skin flora, but with disruption of the skin barrier, this opportunistic organism can penetrate into deeper tissues or the vascular system, leading to infection. These chemical and physical barriers are not completely impenetrable, as tiny breaks may permit an antigen invasion. When the barriers are penetrated, innate defenses are in place to respond to those antigens through the activation of the inflammatory response. The inflammatory response occurs when cells and body tissues are injured, regardless of the cause. Since the inflammatory response is part of the innate immune system, it is non-discriminatory, and the same sequence of response occurs no matter what type of injury or prior exposure occurs because no memory is involved. The innate cells have pattern recognition receptors designed to recognize frequently associated pathogen-associated molecular patterns or danger-associated molecular patterns. The acute phase of the inflammatory response starts immediately after the injury and continues until the threat is eliminated, which may take hours to days. Or the chronic inflammatory response takes over until healing and repair are complete, which may take weeks to months. The acute inflammatory response consists mainly of a vascular response that creates the cardinal signs of erythema, edema, heat, and pain at the site of the injury. These clinical manifestations are the result of the release of preformed mediators and the synthesis of new biochemical mediators from mast cell degranulation. Table 2-2 on page 63 discusses each of these mediators from mast cell degranulation and the key effect from it. Mast cells are non-phagocytic white blood cells, or granulocytes, and are abundantly found in tissue exposed to the environment, such as skin, GI tract, and respiratory tract, and are central to the inflammatory process. Prostaglandin and another mediator cause vasodilation and increased vascular permeability. Immediately after an injury, arterioles in the affected area briefly go into spasm and constrict to control bleeding and the extent of the injury. This brief vasoconstriction is immediately followed by vasodilation, which increases blood flow to the injured site, which will dilute toxins and provide the area with essential immune cells, nutrients, and oxygen. This vasodilation is what also leads to the edema due to increasing capillary permeability. As the permeability increases, leukocytes line the vessel wall in preparation for migration into surrounding tissue. While leukocytes are lining the vessel walls and accumulating, endothelial cells in the vessel walls react to biochemical mediators that cause these vessels to retract. And this retraction is what gives the leukocytes enough room to migrate into the interstitial space and begin the cleanup process of phagocytosis. Figure 2-5 in your textbook is a great depiction of the process of phagocytosis. The systemic response to the acute inflammation includes the development of fever, elevated white blood cell count, and the release of acute phase proteins. Pyrogens are molecules that cause the systemic response of fever and are classified as either endogenous or exogenous. Fever creates an unpleasant environment for bacterial to grow and increases metabolism, which facilitates healing and accelerates phagocytosis. During the acute inflammatory process, the complement system and interleukin, along with other mediators, stimulate the bone marrow to produce more leukocytes, particularly neutrophils. At the site, neutrophils release reactive oxygen species, degrade bacterial walls, and phagocytize microorganisms, and they can extrude their DNA from the nucleus to form neutrophil extracellular traps. Mature neutrophils move rapidly into tissues, while the bone marrow produces and releases immature neutrophils, which are also known as bands, at a very rapid pace, leading to the reason why a high number of immature cells can be detected in blood samples during an acute infection. The most common reactants measured in the serum to evaluate the presence of inflammation are CRP, fibrinogen, and sed rate. Plasma protein mediators are part of the inflammatory response and continuously circulate within the plasma. They are part of three systems: the complement, clotting, and kinin. The complement system is part of the innate immune response, but also instructs the adaptive immune response. Complement proteins are produced by the liver and circulate in the blood, extracellular fluid, and lymph in an inactive state. When a foreign substance invades the body, these proteins become activated, and three pathways are taken to enhance pathogen destruction and participate in the inflammatory response. These pathways are the classical, alternative, and lectin. Regardless of the pathway that is activated, the result is an inflammatory state, pathogen opsonization for the destruction by the phagocytic cells, and alteration of pathogen cell membrane by a complement protein assembled membrane attack complex. The clotting system is also activated during an infection and participates in the inflammatory response by attracting neutrophils to the site of injury causing increased permeability. Chronic phase of the inflammatory response typically occurs because the acute response was not effective in eliminating or repairing the injury or infection. Here is a great visual of the inflammatory response, which is figure 2-4 in your textbook. Now, adaptive immunity, also known as acquired immunity, are defenses within the body's own individual immune system. These defenses recognize and attack antigens that make it through the innate defenses. There are two major approaches, cellular and humoral immunity, and the key cells involved include T and B cells. T and B cells mingle with antigens as they circulate within the body's fluids and peripheral lymphoid tissue, and this interaction serves either to destroy the antigen or to produce antibodies against the antigen. Cellular immunity is a defense approach that is mediated by T cells, which are produced in the bone marrow and enter the bloodstream to travel to the thymus for maturation, hence the name T cell. The naive T cell waits to enter a specific antigen, at which time they differentiate into a different T cell subset. T cells that work to destroy antigens include T helper cells and cytotoxic T cells or killer T cells. Helper T cells can be divided into several subtypes, and figure 2-9 in your textbook describes each of these subtypes. Some T cells die after responding to an antigen, and some become memory T cells or cytotoxic T cells that respond to subsequent antigen exposure. Humoral immunity involves B cells that mature in the bone marrow, where they differentiate into either memory cells or plasma cells, which produce immunoglobulins. These include your IgG, IgM, IgA, and Table 2-3 in your textbook describes each of these immunoglobulins in more detail. Active acquired immunity refers to immunity gained by actively engaging with the antigen, whether this is through an invasion or a vaccine. In an active immunity, the body makes antibodies and protection is usually long-term. An example is getting a varicella infection or chickenpox when you're younger and not getting the disease again, or when the person receives the varicella vaccine and never gets the chickenpox. Passive acquired immunity refers to immunity gained by receiving antibodies made outside the body by another person, animal, or recombinant DNA. This occurs when the person is not actively producing antibodies and protection is short-lived. For example, mother to fetus transfer of antibodies through the placenta and breastfeeding. Infectious disorders. Microbes are all around us, and exposure and colonization of these microbes begin at birth. Many of these microbes are part of the normal human flora and do not cause disease, but they can become pathogenic under certain circumstances and lead to disease. Many microbes cause no effect, are beneficial to the human host, and some microbes are pathogenic and lead to clinically evident infectious disorders. Just an FYI that in the United States, infectious disorders, specifically pneumonia and influenza, are in the top 10 leading causes of death, and lower respiratory infections are ranked as the 4th leading cause of death worldwide. Infectious diseases occur because of an interaction among the agent, host, and environment. The agent is a pathogen which lives, grows, and multiplies in a reservoir, which the reservoir can be human, animal, or environmental. The pathogen then leaves through a portal of exit, such as the respiratory tract, feces, or urine, after which it is transmitted to a susceptible host via an indirect, which should be airborne, or direct, such as droplet or contact, manner. The pathogen must have a portal of entry, such as the respiratory tract, skin, or blood, to the host. The susceptibility of those hosts is influenced by many factors, including genetics and their immune response. Once a person is infected, the infection follows a natural progression, which includes the incubation period, prodromal phase, acute phase, decline phase, and the convalescence phase, which involves a return to good health. Bacteria are single-celled organisms known as prokaryotes, in that they have a nucleus or mitochondrial apparatus. Since they do not have, starting over this slide. Bacteria are single-celled organisms known as prokaryotes, in that they have no nucleus or mitochondrial apparatus. Since they do not have a nucleus, the DNA floats inside the cell along with the RNA, proteins, and carbohydrates. Bacteria reproduces by a process known as binary fusion. Bacteria is classified as gram-positive and gram-negative. Gram-positive bacteria have thicker cell walls and have fibers that protrude outside the peptidoglycan layer. Gram-negative bacterial cell walls, while thinner, are much more complex than gram-positive. There are also atypical bacteria, which remain colorless and do not stain, so they are not considered negative or positive. Bacteria is also classified as aerobic, which means they require oxygen to grow, or anaerobic, meaning they can survive with low oxygen. Bacteria are also classified by shape. Some bacteria are mobile because of the presence of flagellum, and some bacteria have pili, which allow for adhesions and movement. Fungi consist of unicellular yeast and multicellular molds. Fungi have a nucleus with chromosome and mitotic apparatus, and they are non-mobile. The diseases caused by fungi must commonly result in superficial skin infections. Protozoa, like fungi, are mobile due to the presence of flagella, cilia, or pseudopods. However, their cell wall is flexible, and when they invade the human body, they develop a parasitic relationship. Protozoa are usually categorized by their mode of transmission, which is usually oral fecal, leading to intestinal disease, through a vector, such as a mosquito causing blood or tissue infection, or through a site of infection. Helminths or worms are just like protozoa in that their cell walls are flexible, and they are classified as a parasite. There are two groups of worms that cause infections in humans, which include nematodes or roundworms, and the other type are flatworms. Roundworms can cause pinworm and hookworm, and examples of a flatworm include tapeworm. Helminths go through a life cycle that starts as an egg, progresses to a larva, and then an adult. And transmission to human usually involves ingestion of eggs, penetration by larva, or an insect bite. Viruses are simply molecules as opposed to living creatures. They are non-cellular and do not contain a nucleus, cytoplasm, mitochondria, or ribosomes. They also do not replicate independently or synthesize energy or protein, and are made of an internal nucleic core that either contains double or single-stranded DNA or RNA, but not both. Some viruses have a lipoprotein envelope that surrounds the nucleocapsid unit, which can be seen in the herpes simplex virus, hepatitis B, and the Epstein-Barr virus. The envelope is derived from the host cell as the virus exits the cell it has infected. This is called budding. Non-enveloped viruses, or naked viruses, have the capsid protein serve as a site for fusion, which is seen in HPV. The outer protein activates cytotoxic T cells to kill virus-infected host cells and neutralize antibodies. And these same outer proteins are also the target where antibodies bind to prevent the virus from entering and replicating the cells. Enveloped viruses are more unstable, meaning they are more sensitive and likely to be destroyed by heat and detergents. Enveloped viruses tend to be transmitted through direct contact. Many enveloped viruses that are contracted through inhalation, such as influenza and RSV, are rapidly inactivated in the environment, decreasing the risk of transmission from contaminated surfaces. On the other hand, rhinoviruses that cause the common cold are non-enveloped and can last longer in the environment, leading to a higher transmission from contaminated surfaces. Not only are viruses transmitted through numerous routes, the portal of entry also varies. They also have the capacity to evade host immune responses, such as through the reduction of cytotoxic T cells' killing ability and altering interferon synthesis or action. Some viruses also have multiple serotypes, and they can change serotype rapidly over days or months, such as the influenza virus or hepatitis C virus. The ability to change serotype has led to challenges in creating effective vaccines. Many viruses can be completely cleared by the host while others remain in the host. And the ones that remain can either continue to replicate at a low level, like seen in hepatitis C, or temporarily stop replicating, hide from the immune system, and then periodically reactivate like we see with the herpes simplex virus. Prions are similar to viruses in that they are non-living and have no cellular content, but they do not have DNA or RNA, and are infectious transmissible molecules that cause normal cellular prior proteins, which are mainly found in the brain, to unfold in an abnormal manner. This abnormal unfolding leads to prion diseases or transmissible spongiform encephalopathies that have long incubation periods but ultimately lead to rapid progressive neurodegeneration and death. So a virus we are all very familiar with is COVID-19, which was first identified in 2019. It started in China and then spread over the next several months across the world. And as it spread, it mutated, creating several variants. The pathogen responsible for these atypical infections is the severe acute respiratory syndrome coronavirus 2, which is an enveloped, positive sense, single-stranded RNA virus. The virus is mainly transmitted from person to person through respiratory droplets and aerosols by an infected individual who is coughing or sneezing, or even just talking. Viral transmission may also occur through fomites used by or on individuals, such as linens, kitchen utensils, thermometer, and stethoscopes. But this is not considered a major route of transmission. Airborne transmission has not been reported except in specific circumstances in which procedures generate aerosols are performed. Once COVID-19 enters the body, the virus binds to the host receptors and enters the host through endocytosis or membrane fusion. See Figure 2-22 in your textbook. As you all know, clinical manifestations of COVID-19 vary widely and can appear 5 to 14 days after exposure, with the period of greatest infectiousness a few days before the development of symptoms and during the first few days of symptoms. As viral replication and propagation progresses, the disease transitions to the next phase, which is invasion and infection of the upper respiratory tract. This is when a patient may experience fever, malaise, and dry cough. Most people do not progress beyond this phase as their immune response is sufficient to contain the spread of infection. However, about 1/5 of people will progress to the next stage, which involves the lower respiratory tract and progression to acute respiratory distress syndrome. And this is caused due to cells that are responsible for fighting the virus appear, but cause inflammation and lung injury in the process. The host cells undergo apoptosis, which results in the release of more viral particles that then infect nearby cells. This persistent injury from inflammatory cells and viral replication causes diffuse alveolar damage that eventually leads to ARDS. People who are at higher risk for severe disease and complications include those with advanced age, immunocompromised states, and comorbidities. And complications are typically the result of cytokine storms. Page 84 in your textbook lists the complications most commonly associated with COVID-19. Diagnosis includes molecular or viral RNA, antigen, and antibody tests. The antigen test is a rapid option that measures viral load to identify active infection, but they are not effective in identifying early infections, and false positives can occur, and a negative result may need to be confirmed with the molecular test. Both molecular and antigen tests are obtained from the respiratory tract specimens ranging from oropharyngeal saliva to nasal swabs to lower bronchial secretions. Treatment is usually directed toward supportive care, but there are drug therapies available. Hospitalization is sometimes required depending on the severity of the illness, and vaccines are now available which can effectively prevent transmission, severe illness, and future mutations. Other ways to limit transmission include hand hygiene, avoiding touching mucous membranes, social distancing, covering mouth and nose with a mask or other covering when around others, covering coughs, sneezes, and cleaning and disinfecting surfaces. Vaccines were developed to stimulate the immune system to provide protection against infection and avoid the consequences of getting an infection. Vaccination response is influenced by antigen characteristic and dose, administration route, adjuvants added to enhance the modulate response, which can include aluminum that boosts the immune response, or preservatives and stabilizers to keep the vaccine from becoming contaminated and to extend their length of use. The active component in vaccines is the antigen, and the antigen stimulates the adaptive immune response. Live attenuated vaccines create an almost identical immune response as an active infection. Examples of a live attenuated vaccine include the varicella vaccine and the MMR vaccines. Live vaccines tend to give longer immune protection, and these vaccines can cause infections and are contraindicated in those who are immunocompromised and during pregnancy. Inactivated vaccines are made from whole or fractions of viruses or bacterial antigen or the toxin produced by the bacteria. The response stimulated is mainly humoral with little or no stimulation of cellular immunity. The organisms in the inactivated vaccine do not replicate, and multiple doses and boosters are usually needed. Examples of whole inactive vaccines include hepatitis A and polio. Recombinant vaccines are developed through genetic engineering technology and can include the use of pathogens, DNA, genetic modification of a pathogen, and a viral vector, which is a virus that has been modified to insert genetic material into a cell. An example of a recombinant vaccine includes hepatitis B and HPV. A newer type of vaccine includes messenger RNA vaccines, which provide cells with coding for proteins or a piece of a protein to build the immune reaction, including the production of antibodies. The mRNA vaccines do not use live viruses and do not enter the nucleus. An example is the Pfizer and Moderna vaccines developed for the COVID-19 pandemic. Altered immune response occurs when there is a malfunction at any point in any of the numerous and highly complex immune responses and can create a pathologic state. These malfunctions may include exaggeration or hypersensitivity, failure of self-recognition or autoimmunity, or diminution, which is immunodeficiency. Hypersensitivity is an inflated or inappropriate response to an antigen leading to inflammation and destruction of healthy tissue. These reactions can be immediate or delayed and can cause either a localized or widespread response. Hypersensitivity can be classified in many ways, such as type 1, which is IgE mediated, type 2, which is tissue specific, type 3, which is immune complex mediated, and type 4, which is cell-mediated. This reaction can also be classified by the type of antigen the immune system is responding to, such as self-antigens or autoimmunity, antigens from another person, alloimmunity, or environmental antigens or allergies. Type 1 hypersensitivity leads to allergens activating T cells, which are typically the helper cells, which bind to mast cells. The T cells stimulate B cells to class switch and produce IgE antibodies instead of IgM or IgG specific to the antigen, which are commonly environmental. And a reaction to the environmental antigen is termed an allergy. These types of reactions lead to immediate inflammation and pruritus, and repeated exposure to relatively large doses of the allergens is usually necessary to produce a response. The reaction may be localized, as seen in asthma, allergic rhinitis, and food allergies. May also be widespread, which results from the sudden release of mast cells and basophil mediators, and that is termed anaphylaxis. Anaphylaxis is usually the result of an IgE event, but IgG and immune complex and complement reactions may also occur, and these types of reactions are termed immunologic anaphylaxis. There are also non-immunologic reactions that occur when mast cells and basophils are activated with IgE, IgG, or immune complexes. Examples of non-immunologic reactions include Red Man syndrome by vancomycin administration. Treatment of type 1 reactions includes epinephrine, antihistamines, corticosteroids, and desensitizing injections, all of which will suppress the inflammatory activity. Type 2 sensitivity typically involves the destruction of antigens on target cells or tissue. The antigens may be intrinsic or extrinsic. In these types of reactions, IgG or IgM antibodies bind with an individual's own specific cell or tissue antigens, activating the complement system, which results in the destruction or malfunctioning cell. Type 2 hypersensitivity mechanisms include complement activation leading to cell lysis, phagocytosis, and neutrophil or cytotoxic cells destroying the targets. Another type 2 mechanism involves an antibody binding with the cell surface receptor and blocking the activity of this receptor. This is seen in blood transfusion reactions. Treatment for these two types of reactions focus on prevention and includes ensuring blood compatibility prior to transfusions, administering medications to suppress immune activity, and preventing maternal antibody development. Type 3 hypersensitivity involves circulating antigen-antibody complexes that have been inadequately cleared by the innate blood-borne immune cells, which accumulate and become deposited in tissues. Type 3 reactions are not targeted toward a specific organ. However, tissues often affected in this way include kidneys, joints, skin, and blood vessels. The accumulation of the complexes triggers the complement system, causing local inflammation and increased vascular permeability. In turn, more complexes accumulate as neutrophils and macrophages are activated. Examples of these include autoimmune disorders. Type 4 hypersensitivity involves a delayed processing of the antigen by macrophages. Type 4 is not antibody-mediated. These reactions can cause severe tissue injury and fibrosis and includes tuberculin skin testing, transplant reactions, and contact dermatitis from poison ivy. Treatment is disease-specific. Autoimmunity is the immune system's protective nature that presents challenges for patients who require tissue or organ transplants and blood transfusion. This ensures the best possible tissue match for transplant success. There are 4 types of tissue transplants possible: allogenic, syngeneic, autologous, and xenogenic. Allogenic transplants are those in which tissue is used from the same species and is of similar tissue type but not identical. Most transplants use allogenic tissue. Syngenetic transplants use tissue from identical twin of the host. Autologous transplants involve the host and the donor are the same person. For example, a person storing up blood to transfuse to themselves prior to a surgery. Xenogenic transplants include the use of tissue from another species, such as the use of pig heart valves to replace diseased valves in humans. Acute tissue rejections are the most common and treatable type of rejection and typically occur within 4 days to 3 months following the transplant. Acute reactions are cell-mediated, with mainly T helper cells producing interleukin-2 and interferon gamma, causing macrophage stimulation and resulting in transplant cell destruction or necrosis. The patient exhibits signs of the inflammatory process, including fever, redness, swelling, and tenderness at the graft site. The patient may also experience impaired functioning of the transplanted organ. Chronic tissue rejection occurs from about 4 months to years after the transplant, and this is most likely due to an antibody-mediated immune response. Most rejection reactions are classified as host versus graft, also known as when the host is fighting the graft, and the other type of rejection is graft versus host, which occurs when the graft fights the host. Identifying the rejection reaction quickly is crucial to reversing it. Treatment for transplant rejection begins with prevention. Prevention starts with ensuring a tissue match and initiating immunosuppressive therapy for life. Once a rejection is suspected, immunosuppression therapy is intensified to reverse it. There are more than 80 diseases that are classified as autoimmune disorders, and in these diseases, the body's normal defenses become self-destructive. They fail to identify self-antigens within the host from non-self foreign antigens. Autoimmune disorders can occur when things go wrong with tolerance, sequestration, and regulatory mechanisms. Reasons for tolerance failure and a misdirected response are unclear. Autoimmune disorders typically affect women more than men, pointing to possible hormone influences, and there also seems to be familial tendencies pointing to genetic influences. In autoimmune disorders, there are 2 key ways that the immune system attacks itself: by autoantibody or T cell mechanisms. Some autoantibodies can mark an antigen for phagocytosis, and this can occur in autoimmune thrombocytopenic purpura or hemolytic anemia. They can also block receptors, which can be seen in insulin-resistant diabetes, as the autoantibody blocks the insulin receptors. Autoimmune disorders can affect a specific tissue or organ, for example, the thyroid in Hashimoto disease, or may affect multiple systems, which is seen in rheumatoid arthritis. They are characterized by frequent progressive periods of exacerbations and remissions, and physical and emotional stress tend to trigger the exacerbations. Treatment is disease-specific. Systemic lupus erythematosus, or SLE, is a chronic inflammatory autoimmune disorder that can affect any connective tissue. It is seen more frequently in women, which is contributed to X chromosome-related issues and to the effects of estrogen, progesterone, and prolactin on the immune system. It is thought that in SLE, B cells are activated and autoantibodies bind with autoantigens and form immune complexes. And these immune complexes fight against the body's own tissues, including red blood cells, platelets, and lymphocytes. Hyperactive helper T cells and subdued suppressor T cells are thought to create a prime environment for B cells to overproduce. It is unpredictable, but most commonly affects the heart, joints, skin, lungs, blood vessels, liver, kidneys, hematologic function, and nervous system. See page 95 for a table that lists the most common manifestations of SLE. Diagnosis can be challenging due to the wide variety of symptoms and organ involvement. The American College of Rheumatology and European League Against Rheumatism have developed a list of clinical criteria. When a person has 4 or more of the criteria, the diagnosis of SLE is strongly suggested. And some of these clinical criteria include alopecia, synovitis, hemolytic anemia, leukopenia, and oral ulcers. See page 95 of your textbook for the full list of clinical criteria for SLE diagnosis. There are also labs that may be beneficial, including a CBC, CMP, C3 and C4 complement levels, direct Combs test, and even possibly a tissue biopsy. Treatment is directed at symptom management, including sun protection, balanced diet, stress reduction, exercise, and sleep. NSAIDs may be used along with corticosteroids, and antimalarial drugs may also be used to treat fatigue, joint pain, rash, and pleural inflammation by suppressing the immune system. Primary immunodeficiency includes over 350 disorders. Innate defects such as dysfunctional, inadequate, or absent phagocytic capacity can be present. Receptors on cells and the ability of cells to trigger important cellular processes can become defective, and the complement system can also be deficient. Clinical manifestations can vary, but suspicion for primary immunodeficiency includes infections that are severe or require hospitalizations or IV antibiotics, they're persistent, and that they will not completely clear or clears very slowly, unusual, caused by an uncommon organism, they are recurrent, or there is a familial tendency. Diagnosis occurs with newborns, or can occur as young as newborns, and that all 50 states screen newborns for severe combined immunodeficiency. Diagnosis and management is typically handled by immunologists with primary immunodeficiency experience, and labs may be completed, including CBC, flow cytometry, antibody testing such as IgG, IgM, and complement testing. Genetic testing may also be completed. Patients with peripheral immunodeficiency may include prophylactic antibiotic administration. Vaccine administration may be contraindicated in some patients, so it is important to stay up to date or know where to look at the guidelines for vaccine administration. Secondary immunodeficiency includes HIV and AIDS, and as most of you know, AIDS is a deadly sexually transmitted disease caused by HIV. HIV attacks and weakens the immune system. HIV is transmitted through direct contact with infected blood or body fluids and is contracted when those body fluids come into contact with mucous membranes of the mouth, penis, vagina, or rectum. Sexual intercourse is the highest incidence, followed by injection drug use involving needles or a syringe sharing and other equipment sharing. As a retrovirus, HIV requires a host to survive, and HIV contains 2 copies of single-stranded RNA, and it is enveloped spherical virus. The life cycle of the virus is important as medications are targeted toward a part of the cycle. Here's a picture of the HIV life cycle, which can be found on page 99 of your textbook. Once the virus gains access to the body, the virus targets macrophages, dendritic cells, and CD4 helper T cells. The HIV outer surface has a glycoprotein 120 that binds to the CD4 on the dendritic cells. Macrophages are also a target, and the virus glycoprotein 120 needs to bind with a core receptor known as the chemokine receptor, which allows for viral entry. To attach to the T cells, the virus glycoprotein 120 must attach to another co-receptor known as a chemokine receptor 4 and the CD4 cell. Once attached and bound, the second part of the life cycle is known as fusion. which is the joining of the virus protein and the CD4 membrane allowing entry. Once inside the CD4 cells, it uses an enzyme called reverse transcriptase to convert the viral RNA to DNA. The viral DNA then becomes integrated within the CD4 cell's own DNA with the help of integrase. The infected CD4 cells reproduce new viral RNA, viral capsid, and other HIV building blocks. The HIV, RNA, and building blocks go to the surface of the cell to assemble into immature and non-infectious HIV. Once out of the cell, protease breaks up the protein into smaller chains, which makes mature infectious HIV. During this, the virus replicates and infects susceptible cells, releasing millions of viral copies into the bloodstream. Each viral copy then attaches to new CD4 cells to start the process all over. Symptoms can be subtle at first and may progress to mucocutaneous lesions, making the suspicion for HIV higher. This stage is considered the acute retroviral syndrome and typically occurs 4 weeks after infection. During the acute period, viral load fluctuates and then reaches a set point. During this, the person may remain asymptomatic for months to years as the virus continues to replicate but not as fast. This stage is called the clinical latency or chronic HIV infection stage. Individuals may be in this stage for up to 10 years before they move into the late stage of infection, which is AIDS. Children who are HIV positive may experience lymphadenopathy with hepatosplenomegaly early in the course, difficulty gaining weight, difficulty growing normal, problems walking, delayed mental development, severe forms of childhood illness such as ear infection and tonsillitis, and opportunistic infections are most prevalent in children as well, which can include wasting syndrome and oral thrush. Diagnosis can be established through labs as early as 2 weeks after exposure. There are 3 categories of testing: antibody-only testing, combination antigen and antibody testing, and molecular nucleic acid tests. Once HIV is diagnosed, viral RNA is measured quantitatively, also with the NAAT test, which is known as the viral load measurement. The plasma viral load, or number of viral particles per milliliter of blood, is mainly used to monitor disease status and management. There is no cure for AIDS, and antiretroviral therapy is used to control the reproduction of the virus and slow progression of the disease. So ultimately, the key to preventing infectious disease is building a strong immune system. The immune system requires early exposure to antigens to operate optimally because it is a memory system. Research suggests that avoiding over-sanitizing our environment can increase exposure to microbes earlier and help us all develop a strong immune system.